present with fatigue, sometimes can be confused with depression. But the definition of anemia is either a hemoglobin count that's low or a hematocrit that's low. So hemoglobin under 13.5 for men or 12 for women, hematocrit under 41% for men and 36 for women. Just means that we have a reduced ability to carry oxygen to the body. So the reasons that you would have an anemia are the same reasons you would have a deficit of any other thing. If you're not making enough, if you are destroying too much of it or losing too much of it, then you're going to have a deficit, and it's the same with anemia. This table shows some of the more important causes of anemia and breaks it up into microcytic, macrocytic, and normocytic. We'll talk about this in a second about what those numbers mean, but basically is talking about the number of cells and I'm sorry, the size of the cells, not the number of cells. And the most common of these is the iron deficiency anemias. The patients that you're going to see with this are commonly adolescent girl who's just started menstruation, a pregnant female who's donating her iron to a greater cause, and the elderly, men or women, who are not getting enough iron in their diet because of socioeconomic conditions or maybe due to dementia and not understanding what they need to eat or remembering to eat. And also in the elderly, you have an increased incidence of cancers that may lead to bleeding. These macrocytic anemias are often due to a decreased production of red blood cells, especially in B12 deficiency, folate deficiency. These are deficiencies in vitamins that are needed for DNA production. And then your normocytic anemias can be broken up into non-hemolytic and hemolytic. So either we're destroying red blood cells or we are losing red blood cells, as in sometimes in anemia of chronic disease, or we're just not making enough red blood cells, like in aplastic anemia, kidney disease. The microangiopathies are examples of mostly mechanical destruction of red blood cells, but also blood loss can be caused by these microangiopathies. The major symptoms of anemia, these patients will come in with fatigue as the top of their list, but that's not sensitive or specific to anemia. You'll want to be checking for skin changes, respiratory problems, cardiopulmonary problems, intestinal and muscular issues. In the history, you'll be asking about tarry stools. This would be indicative of blood due to especially a colorectal cancer, but also can be due to other types of bleeding in the GI. Pain, rheumatoid arthritis, which is associated with autoimmune destruction of red blood cells, renal failure. Remember, the kidneys are where erythropoietin is made, which is the major hormone to stimulate red blood cell production. Ethnicity is associated with certain types of genetic anemias like thalassemia that you see in Mediterranean populations, and medications Many of them can cause anemia as well. On physical exam, you look for some of the things that we saw in the chart back there, like pallor, jaundice, lymphadenopathy, which may be an indicative of some kind of a autoimmune or inflammatory process, as well as malignant processes. Hepatosplenomegaly is common in spherocytosis, sickle cell anemia, some of the anemias that involve changes in the red blood cell size and shape. Bone tenderness may be indicative of a some type of a myeloproliferative disorder or a cancer. Petechiae and ecchymosis can be signs of loss of blood, bleeding problems that can lead to anemia. Look for signs of infection and definitely check the stool sample for blood. The lab values involved are MCV, which is the mean corpuscular volume. The mean corpuscular volume is the size of the red blood cell, or the volume of the cell. So if we back up to this slide where we talk about microcytic versus macrocytic and normocytic, the mean corpuscular volume can help us start thinking about different categories of anemia. So if we have mean corpuscular volume below 80, we'll start to think about iron deficiency and some of the thalassemias, possibly lead poisoning, which is a lot less common these days. Or if we have high MCV levels, start to think about the macrocytic anemias. The mean corpuscular hemoglobin gives us some of the same information. Mean corpuscular hemoglobin concentration helps us to identify changes in red blood cell shape. For example, spherocytosis will have a characteristic mean corpuscular hemoglobin concentration. Reticulocyte count will help us to know if we are producing new red blood cells. White blood cell count and differential can lead us to diagnoses in which we may be producing no blood cells at all, white or red blood cells, as well as can help lead us to inflammatory processes. Nucleated RBCs, platelet count, pancytopenia, and iron transfer and ferritin are especially helpful when we're talking about iron deficiency. So the treatment is as varied as the causes, so we need to worry about removing the underlying cause, whether that be stopping the hemorrhage that's causing it, removing a tumor, replenishing deficits like iron deficits, folate deficits, B12, and giving blood products, or also